Hi, thanks, Dr. Cohen. It was a great talk, as usual. Last but not least, we have Dr. Matthew, who comes to us from Stanford, and she's going to talk to us about several pediatric infectious diseases on the rise. I know she's going to be talking to us about measles, pertussis, mycoplasma, so a bunch of really cool stuff. Dr. Matthew?
Good morning, everyone. Thank you so much for this opportunity to come and present. I know I'm standing between you and lunch, so I appreciate all of you, being here and listening. My name is Roshni Matthew. I am a pediatric infectious disease physician at Stanford. I am also the medical director for infection prevention and control. I figured I would talk about a few pediatric infectious diseases that have been on the trend up, just to give you sort of an overview of those. I have no disclosures. So the objectives are to understand the epidemiology of 5 pediatric infectious diseases that are on the rise, review key clinical features, diagnostic tests, and management. But of course, there are 5 infections to go through, so this will be just very, basically a framework of what to think about. I figured I would go case by case, but I think you guys will immediately recognize these things. Some of these patients we saw, and so I just building it up on the experience that we had. This is a 12-month-old who presents with fevers, diarrhea, and non-productive cough for 4 to 5 days. The fevers have increased now to a Tmax of 107 Fahrenheit. They also have a new onset of rash, faint, diffuse erythematous that began on the face and went down to the trunk and extremities. The patient was admitted to our hospital for tachypnea and respiratory distress. On further history, infant returned from a trip to Yemen 1 week ago. Immunizations are up to date, but is yet to receive 12-month vaccinations. In the ED, they had RSV, flu, COVID that were negative, blood culture sent and pending, urine analysis negative. This was from last year. Which infectious disease is very high on your differential? How would you make the diagnosis? What is an immediate patient placement plan to minimize exposures? And who should you notify? You can all think about it in your minds. But it should be fairly obvious. This patient ends up having measles. So think measles, so consider measles in a patient presenting with a febrile rash illness, especially if unvaccinated for measles or traveled internationally in the last 21 days. As you can imagine, this is a little old. You don't have to travel internationally. Basically, you can travel. So obviously in pediatrics, febrile rash illness is a very common presentation. So the point is to remember measles somewhere in the back of our minds whenever we see a child with measles and consider the epidemiological risk factors. So the symptoms of measles, so it's high fever plus the 3 Cs, so cough, coryza, conjunctivitis. That is considered the prodrome symptoms of measles, and Koplik spots, which probably none of us will see in reality, is because it happens in such an early phase of measles that by the time people think of measles, that's gone. But Koplik spots is considered pathognomonic for measles. These are white enanthema that can be seen in the buccal mucosa. So during the prodrome, the patient may not may not have a rash. So the rash develops actually 2 to 4 days after onset of the prodrome. And the rash has this typical finding of beginning at the hairline behind the ear and from the face going down to the trunk and then to the extremities. So someone taught me that it's like somebody poured paint on top of your head. So the rash can appear different based on the skin complexion. So in light-skinned children, it would look red, but in darker complexion patients, it can actually be harder to see, so something to remember. This is the epidemiology of measles. So measles, one of the vaccines for measles was licensed in 1963, and you can see that the trend has been downward since then. The live vaccine was licensed in 1968, and so it has continued to go down in terms of numbers. So you can see on the y-axis, the numbers are in hundreds of, so it's 500,000. So it's really high. So the number of people who had measles before the vaccination was nearly all of the population. You can see there that in 1989, the second dose for measles was recommended. In the year 2000, measles was considered declared eliminated in the United States. We'll talk a little bit about that in a minute. So this is from 1985 to present, so that's till September 2nd. And you can see the y-axis, again, it's now gone down. It's like 25 to 30,000 is the max. And so you can see that the trend has been quite fine. And then this is another next set, so 2000 to present. So again, the y-axis, the number of total cases of measles is considerably lower. We have had blips in our measles cases since the elimination. So in 2014, we had the Disneyland outbreak. Then in 2019, we had the outbreak in New York. So we've had cases happening from time to time. I think what made everybody nervous in 2025 is that we've had more cases by September than we've had in a year since like 1992. So obviously it's ongoing, but the numbers are trending in the right direction. So we had that high spike happen March, April, and such, and then now it's on the downward trend. On the right, you'll see the map of the United States, and the highest number of cases were in Texas. Gaines County was the epicenter. But we've had cases most of the country, including in California. This is the current state of the outbreak. So as of September 2nd, there have been 1,431 cases. Most of them have been in less than 19 years of age, and most of them have been in either unvaccinated or unknown status of vaccination. There have been hospitalizations. 21% of our the young pediatric patients, so less than 5 years of age, have been hospitalized. And there have been 3 deaths in 2025. And this is a large number considering we've not really had any deaths for many, many years. Why is there more measles activity? One of the major reasons is that the MMR coverage among kindergartners has gone below the threshold of 95%, which is what we want to have for herd immunity. So in 2019-2020 school year, it was about 95%, and in 2023-24, it dropped down to 92% across the United States. And then there are pockets where it's way lower than 80%, so it really depends on where you live. In California, you'll see that we are in the 95% overall, but there are areas in California as well where the rates are lower. And there's measles activity all over the world. So in the very dark blue are where there have been more than 1,000 cases reported. Unfortunately, United States is in that mix. But so it's just a plane ride away to get measles. So those are the reasons for measles, increased measles activity. This is just an example of a little write-up on why it matters if the US loses its measles elimination status. So measles elimination status is gained when a country does not have endemic spread of measles anymore, and sustained over a 12-month period. So all of the Americas actually have an elimination status, not just the United States. So really what happens if you continue to have measles, is that we'll be practicing in a whole different environment. So anytime a child comes in with fever and a rash, you'll have to think about measles. How do we room this child? So that's a practical aspect for medical professionals. But it also means that daycares, preschools, so suddenly there might be an outbreak, you may have to close down schools or daycares. People traveling to the US may need to quarantine when they go back to their the other countries, so tourism and things may be impacted. So there could be huge impacts of going back to a time when we had measles activity more rampantly. So 2 doses of measles MMR, which is how we get measles vaccine, is 97% effective at preventing measles. And 1 dose is 93% effective, and thus we came up with the 2-dose regimen for our kindergartners. So children need those 2 doses. First dose is given at 12 to 15 months, and the second dose at 4 to 6 years of age. Infants younger than 12 months can get their first MMR vaccine between 6 and 11 months if they are, traveling. And that does not, however, count toward their 2-dose requirement for kindergarten. People who got vaccinated in the time frame of 1963 to 1967 may have received the inactivated measles vaccine, so they should get a vaccine, the current vaccine. But if you're born before 1957, you're considered to be immune to measles. So how do we diagnose measles? Measles is diagnosed with detection of the measles virus PCR in different samples. You can send nasopharyngeal sample, urine, or blood sample. Getting more than 1 site increases the sensitivity of the test. You can also send an IgM for measles. However, IgMs can have issues with false positivity, and so the nucleic acid test would be preferred. Measles cultures is not really done routinely. The big issue with measles is its contagiousness. So for the individual patient, it is very important as well because it can cause a lot of issues, complications. So the more measles we have, the more complicated cases we will have, more deaths we will have. Measles has a significant impact on the immune function of the patient. So there are definite consequences for the individual patient, but it is also highly contagious. So measles is one of the most contagious of infectious diseases, and so if one person has measles, they can infect 9 out of 10 people they come in contact with if they are susceptible to measles. And during COVID, we learned about R0. R0 is the number of secondary cases you can result from the one infected person, and that for measles is about 18. So that's why it's considered to be one of the most infectious, contagious infections. So this is a nice picture that shows about measles, just to explain the infectious period of measles. So the first part of it, where it says incubation period is up to 7 to 21 days. So thus the 21 days about thinking about measles from the time of travel or other epidemiological risks. Most people get the symptoms of measles within like 8 to 12 days of exposure. During that period, one is not infectious. Then comes the prodrome we talked about, so fever and the 3 Cs, and then the rash. So the patient is considered to be infectious 4 days prior to onset of rash to 4 days after onset of rash. So this can be very tricky because even before the rash begins, the patient is infectious. So they may have come to clinics, they may have come into the hospital for the fevers. Nobody had really thought about measles because the rash never happened. But that becomes important when you try to figure out exposures. And then during the period of the rash is when the fevers actually go up in its intensity. And then after day 4, the rash fades and the fever also you have defervescence as well. So that becomes an important part of the investigation to identify the period of infectiousness. So what is the first thing you should do when you see a patient who may have measles? And I'm talking about, in a clinic or hospital setting, is to place the patient in a specific type of room. It's called airborne infection isolation room. That means that the room usually has like a negative area, so preventing the airborne infection from actually leaving the room. Many clinics will not have airborne infection isolation room. In that case, you would place the patient in a private room with the door closed. And if the patient is able to wear a mask, they should, and any healthcare providers that are going in to see the patient will need to wear a respirator, so N95 or equivalent. So this becomes very important because this is the only way to prevent further exposures. So when you talk about exposures, a couple of things to think about. So if a patient gets diagnosed with measles and the patient was in your facility a few days before, the main things to figure out is when was the patient in the facility? So were they in that infectious period we talked about? And then what was the location of the patient? Was the patient placed in airborne isolation? Was the patient in the waiting room? For how long was the patient in the waiting room? And if people wore appropriate PPE when they were seeing the patient. So these all become relevant as part of the exposure investigation. So measles exposure needs timely evaluation, and that's because the interventions you do, so post-exposure prophylaxis, are very much time constrained. So if you have an exposure and a person could get measles vaccine as a part of post-exposure prophylaxis, that has to be done within 3 days. If you're going to get immunoglobulin as a post-exposure prophylaxis, such as for pregnant patients or immunocompromised hosts or young babies, they'll have to get it within 6 days. So there is a timeliness to this exposure investigation, which can be quite problematic because the scale of exposure can be a big one. So sometimes the exposures, because we didn't know it was measles, can be on the scale of hundreds. So this becomes time intensive and personnel intensive. Going to the next case and next infectious disease. This is a 2-month-old presenting with cough, gagging, and apneic episodes. And the baby had only a history of rhinorrhea, no fevers. The complete blood count with differential done in the ED shows a WBC count of 50,000 with lymphocyte predominance. Infant is admitted to the PICU for respiratory distress. This is a made-up case, but I've put in all the little buzzwords so you guys can guess. It's a 2-month-old, has apnea, and WBC count of 50,000 with lymphocyte predominance. Yes. So this is indeed pertussis. So pertussis, this is the epidemiological curve for pertussis from 1922 to 2023. So we had a vaccine called DTP, so this is not DTAP. This was before the acellular pertussis, and that's very early on. And you can see how DTP really reduced the incidence of pertussis. The acellular version came into being in the 1990s, and since then we've had blips of cases, so you can see that the trend has been sort of on the rise since the introduction of the acellular pertussis. And the thought is that the waning immunity that happens is because of the acellular pertussis is not the same as regular pertussis. So this is the curve of incidence between 1990 to 2023 by age group. So you can see the highest curve in green is the less than 1 year of age, so they have the highest incidence of pertussis, and then the rest of them sort of also have, there are cases, but it's substantially lower. You can see that the trend for the less than 1 year old has been decreasing, and this has been ascribed to the impact of maternal vaccine strategy that was introduced in 2012. So pregnant patients now receive Tdap during every pregnancy. So this is another graph that shows the reported pertussis cases between 2019 to 2024. So you can see how after COVID through like 2023, we barely had any pertussis, but it's been on the rise since then. There was a change in definition at some point, so some of this rise could be from that, but the general thought is that there was a sort of back to pandemic and probably more than back to pandemic, pre-pandemic levels. This is the graph showing reported deaths due to pertussis, and this has trended downward, which is reassuring. You can see the dark blue is the infant deaths, so this is by age, and they had the highest mortality, and that has been trending down. This is the only information I found on CDC about pertussis trend in 2025. So it just says that in 2024 we had a huge spike, but that's been going down. But the expectation is that we may have more cases this summer and fall. This is a slide that shows the current vaccination recommendations. So DTaP is part of the childhood immunizations. So there are a number of, like 5 DTaPs that they get by 4 to 6 years of age. And then there's the Tdap that's done at 11 to 12 years. And Tdap in pregnancy, and then Tdap for adults as well, and with boosters for just the TD after. Just a brief word about efficacy versus effectiveness. So the efficacy talks about what is the impact of the vaccination during, as reported through studies. And so you can see how DTaP protects children, 98% of the children within the first year of the dose, and about 71% after 5 years of getting the last DTaP. And for adolescents who get Tdap, it's about 73% in the first year, and it declines to 34% 4 years after vaccination. And there's also about the impact of pertussis vaccine in pregnant patients, and it reduces the risk of infant pertussis up to 78%, and reduces hospitalization by 90% in less than 2 months of age. In California, they did the study on vaccine effectiveness, which is the real-world information on the impact of vaccine. And so they looked at Tdap and adolescents, and you can see that within first year of vaccination, the vaccine effectiveness was at 68%, and it decreases to like 9% at greater than or equal to 4 years. So it's significantly lower. And this, again, is because of it's considered to be the waning immunity associated with the acellular pertussis. I believe there's work going on in trying to figure out how to make better vaccines, so that's ongoing work. This is pertussis, so it has a catarrhal phase, a paroxysmal and convalescent. It's the catarrhal phase which is very nonspecific, so runny nose, low-grade fevers, occasional cough. That's where the patient is actually highly contagious. And then it's the paroxysmal phase, which is the whooping cough symptomatology. That is where also the infants come in with apnea. And then there's the convalescent phase that can go on and on with the chronic cough. Really, our impacts for treatment are best done at the catarrhal phase. So that can be tricky because no one may be thinking about pertussis, but would consider this, say there's an exposure and someone comes down with symptoms. Diagnosis of pertussis is again with PCR testing of nasopharyngeal specimen. And a clue to pertussis in the very young babies is with this absolute lymphocytosis that can be seen. So the antimicrobials, we treat with azithromycin, earlier the better. Once you enter into the, after the paroxysmal phase, actually the impact of antimicrobials is probably much lower. And azithromycin is also what is used for post-exposure prophylaxis. The CDC actually recommends post-exposure prophylaxis for really household contacts, particularly for high-risk household contacts, and not really mass prophylaxis like in school situations, for example. Going to the next infectious disease. This is a patient I saw last year. 6-year-old, previously healthy, fully immunized patient presents with 1 week of cough and fevers. Chest x-ray shows a right upper lobe consolidation. Patient was started on amoxicillin for community-acquired pneumonia. Patient continues to be febrile after 3 to 4 days, and a repeat chest x-ray shows white out of the right upper lobe. Patient has saturations in the low 90s, and patient is admitted for management. What are the pathogens to consider? What empiric antimicrobials would you consider? This is a very broad question, and we think of so many different things that could be happening, but I just wanted to share about Mycoplasma pneumoniae. Mycoplasma pneumoniae is an atypical bacteria, atypical because it lacks a cell wall. It basically enters into the host cell. It replicates intracellularly. It produces a toxin. It's one of those infections that can be quite a mimicker, and it can hide, and so it can evade the immune system and can cause issues because of these reasons. It's a very common cause of community-acquired pneumonia in school-age children. Mycoplasma goes through periods of waxing, waning. So it occurs about every 3 to 7 years, you'll see a spike. It has long incubation period, and it thus contributes to lengthy outbreaks. Most often, Mycoplasma presents with acute bronchitis or upper respiratory tract illness symptoms, which are self-limited. Approximately 25% of infected school-age children will develop a pneumonia. This is the walking pneumonia that we hear about. Mycoplasma can be one of a mimicker, like syphilis, I suppose. It can manifest with very different extrapulmonary symptomatology. Particularly problematic is the CNS manifestations, so they can present with aseptic meningitis, encephalitis, so different types of CNS manifestations, but could also present with cutaneous manifestations and mucous membrane changes. There is this entity called Mycoplasma-induced rash and mucositis, which can look almost like an allergic reaction like Stevens-Johnson, or so it can be a little confusing. So this is a presentation of Mycoplasma as well, and it can cause other entities like hemolytic anemia and glomerulonephritis. Mycoplasma is also diagnosed with nucleic acid amplification test. It is usually performed on nasopharyngeal swab, but the oropharyngeal specimens can actually be sometimes more sensitive. It can also be done on other fluids, sputum and BAL. It is available as a standalone test, but it's also available as a multiplex with other respiratory pathogens. Serology is, I think, more widely available, but its utility in making a diagnosis for an acute infection is limited. So I'll show a few curves of Mycoplasma. So this is Mycoplasma. So in the bars show the total number of tests for Mycoplasma that were performed between 2018 and 2023. And in the blue line is the Mycoplasma percentage positivity. So prior to 2020, there were quite a bit of positive rate of Mycoplasma whenever the test was sent for that purpose. And then after the 2020 to 2023, we almost did not see any Mycoplasma. And this is true about this study, which was published by CDC nationwide, and it was true in our institution as well. And in 2023, late 2023, we started seeing the rise in Mycoplasma. This shows pneumonia ED visits attributed to Mycoplasma between November 2023 and November 2024. And you can see quite the spike that has happened, but also of interest is the age group impacted. So Mycoplasma is typically considered in school-age children, so not really in the less than 4-year-olds. But the graph actually shows how it significantly impacted the infants as well as the 2 to 4-year-olds. And there's, of course, the 5 to 17-year-olds that we know of. So this was interesting. This particular graph comes from the BioFire, the company that makes the test, and they also saw this increase that happened in late 2023 to 2024 in their number of positive tests. This is another publication from CDC that looked at hospitalized children with community-acquired pneumonia that ended up being Mycoplasma positive. So the dark blue bars are community-acquired pneumonia hospitalized patients who were positive for Mycoplasma. Sorry, the dark blue are community-acquired pneumonia not associated with Mycoplasma. And the light blue is community-acquired pneumonia due to Mycoplasma. And the black line is the percentage of community-acquired pneumonia caused by Mycoplasma infection. So you can see how that Mycoplasma contributed to a substantial number of cases of community-acquired pneumonia in hospitalized children. This just took it out of that same graph. So the number of hospital discharges of children with Mycoplasma-associated community-acquired pneumonia sharply increased in 2024, accounting to up to 1/2 of the hospitalized children with community-acquired pneumonia. This number included children less than 5 years of age, a group in which this has historically been less common. Data on length of hospitalization and intensive care unit admissions indicate that Mycoplasma pneumonia infections in 2024 were not more severe than 2018 to 2023. So I suppose that is slightly reassuring. So this looks at ED visits. So this is from 2024 to 2025, but this ends in May of 2025. So the trend is on the down. So one can hope that we are probably going on the downward, and maybe we will have a span of time we won't have much Mycoplasma, but only time will tell, just given the history of Mycoplasma. The treatment is, if you're choosing, so the treatment of Mycoplasma is controversial. Its impact on disease is uncertain, but if you're going to treat, you would treat with azithromycin. But it's important to remember that macrolide resistance has become a big problem in many parts of the world. This map shows the dark color is the areas where there is high level of macrolide resistance. For example, in China, it's upwards of 80%. Some studies like 90, 100%, so it's like really high. Japan, Taiwan, and Italy is another place where there's reported macrolide resistance. But in the United States, it's less than 10%, so we still use azithromycin. Going to the next case, this is a 3-day-old X34-weeker with severe respiratory distress, thrombocytopenia, direct hyperbilirubinemia. So for concerns of congenital infections, several labs were sent. So this is a usual testing for if you're worried about congenital infections. So CMV, toxoplasma, RPR, HSV, HIV. RPR returns at 1 to 256. What are the current recommendations for screening for syphilis during pregnancy? What resources do we have to guide management of an exposed neonate? So congenital syphilis has been on a rise. So you can see the graph. So this is 2012 to 2022. So the numbers have consistently gone up, just experientially as well. When I was a fellow, now more than 10 years ago, I didn't see any congenital syphilis consults, and then now we see this routinely. So this has become a real problem. I won't go through this, but I just wanted to share the resources that are available. Syphilis diagnosis in pregnancy and workup in neonates has a lot of algorithms. So syphilis testing in pregnancy has to be done. So the ACOG recommends syphilis testing at the initial encounter, at third trimester or 28 weeks, and at delivery. So that's the current recommendation. The other important thing about maternal syphilis is that penicillin G is the only medication, benzathine penicillin is the only medication that is proven effective for syphilis in pregnancy, and we have a national shortage of benzathine penicillin. This is the Red Book chapter. There's a Red Book chapter on syphilis, hugely helpful. Again, I will not go through this, but anytime we get called about a pregnant patient who has a positive RPR during pregnancy, and what do you do with the baby? How do you evaluate? What do you treat? Do you not treat? All of that is available through this algorithm. Went through that. This is last but not least. 14-year-old, previously healthy, fully immunized patient presents with 2 weeks of cough, fatigue, low-grade fevers. Chest X-ray shows a consolidation on the left lower lobe. Patient was started on amoxicillin. For community-acquired pneumonia, patient has had no improvement after 3 to 4 days, now with increased shortness of breath. A repeat chest X-ray shows increased left lower lobe consolidation and apparent pneumonic effusion. Patient has saturations in the low 90s, and the patient is admitted for management. A month prior to onset of illness, patient had traveled to Central Valley for a soccer tournament. This is a real situation. The last sentence was just added for fun, but this is, again, a clue to what this could be. Which infectious disease is very high on your differential? How would you make the diagnosis? What are the treatment considerations? So this is cocci or valley fever. So Coccidioidomycosis is particularly prevalent in California, Arizona, Nevada. So those are the areas, and you can see certain dark areas that have much more disease, much more prevalence than the lighter shades. So this is a diagnosis we in California should be very familiar with because there is a lot of cocci. So this is from California Department of Public Health. So this shows essentially the number of cases between 2023, 2024, and 2025. And anything that's marked with orange has had an increase. So many jurisdictions have seen an increase. The darkest orange is Monterey, which has seen an increase of 200 to 300%. But there's cocci anywhere in California, so we have to be aware of this condition. Coccidioidomycosis is caused by fungus Coccidioides. It has 2 species, Immitis and Potpourri. The Immitis is what is seen in California. It is acquired through inhalation of spores. It's not transmitted human to human except through organ donation. And most people who get cocci are either asymptomatic or have mild symptoms, may not even come to care. And the symptoms of cocci can range from fatigue and some respiratory symptoms, but also night sweats. They can have arthralgias, myalgias, and rash. Erythema nodosum is one of the skin rashes that can be associated with cocci. So most cocci is primarily pulmonary. About 5 to 10% of them have complicated disease that require them to be hospitalized or need additional care. Disseminated cocci, which is really quite severe, occurs in about 1% of the cases. Disseminated, particularly the CNS version of it, can be very can be very complicated. Anyone can get cocci. You do not have to be immunocompromised to get cocci, including disseminated cocci. Risk factors, so there are certain specific at-risk populations. So African American race or Filipino ethnicity, HIV, AIDS, organ transplant, diabetes, pregnancy in women, and use of immunosuppressive medications. These would place you at higher risk for disseminated disease. We have serology testing for Cocci. UC Davis is our reference laboratory. And we can also diagnose Cocci through cultures, through different pulmonary specimens, but can also be from CSF, depending on or bone joint. So treatment considerations, really it depends on whether you have, what version of Cocci you have. Most people don't need any treatment. If you do come to care and you fall in the first bucket, which is uncomplicated pulmonary Cocci, that means you do not really have risk factors. You don't even need any antifungal. You just need close follow-up. But if you have complicated Cocci pneumonia, so extensive pulmonary involvement or symptomatic cavitary disease, or you have risk factors, at least in pediatrics, we go for fluconazole. Disseminated Cocci, so such as Cocci meningitis, would require a lot of multidisciplinary care and may involve multiple other antifungals. That was it. Thank you so much. Happy to take any questions.
Thank you so much. That was a wonderful review. Over here, Grace Hasid from San Mateo Medical Center. I just wanted to ask, any thought of why Mycoplasma is on the rise, or was on the rise last year, and we don't know what will happen this respiratory season, but is anyone conjecturing anything? Why?
I don't know the answer. I wonder also about some of these rise that happened after COVID.
Yes.
So for years, we didn't have many infections. Mycoplasma was one, but there were others that also seemed to have quite disappeared. And then it came back with a vengeance, like RSV. You know how RSV, we had that huge rise in RSV cases a few years ago in children. I wonder if Mycoplasma is a similar story, and maybe that. The other thought is, are we diagnosing more? Do we have more access to tests? So those would be some thoughts. But it's interesting because a lot of these were hospitalized, so I would imagine that we should have been able to capture this even before. So it's very curious, but I don't think we know.
Yes, and one thing I just want to say about pertussis, I know for clinicians and people who see, or anybody working in the community, you know, with infants, it's the apnea. They can look cyanotic because they just, you know, when they're tiny infants. Mm-hmm. But for adults, it's coughing so severely that people actually fracture their ribs. Yeah. They vomit because they're coughing so persistently. So, but as clinicians, we have to think of these diagnoses, because if you don't treat during the appropriate time, you know, that patient, and we, you know, we've had a member of our staff, one of our chiefs of services, got pertussis in his adult life, obviously, and he was, you know, coughing to the point that he broke a rib. Mm-hmm. Went to Stanford, saw the ER doc at Stanford, who said, "Oh, I had pertussis. I've been coughing for a year." And it's, you know, so these are diagnoses that this kind of lecture is so helpful. And I know where everybody wants to go, but I just want to thank Dr. Salanave for her incredible work and making this happen, making you come here and teach us. Thank you, thank you, thank you.
Thank you. It was a great talk. So just one quick question. So you talked about how efficacious the MMR vaccine is, especially after 2 doses. Is there any worry about waning immunity?
Yeah, we get this question a lot, and so we get this question about, should we be re-immunizing like our healthcare workers who are, you know, seasoned? But the current recommendation is to not, that we are not yet concerned about waning immunity, so yeah.
If I can just I am in charge of employee health, so for our hospital and clinics. So basically, we check titers of people. If there's any question, if we know people are, of a certain age, obviously there are exceptions. You're born at 56 or beyond, you're considered immune, but we still will check a titer to be sure before that person has to go into a room with someone with measles, because we now have it happening in the country, right? So, and always we've had them from travelers, but bottom line, we do check a titer, and in general, though, CDC recommends if you've had 2 known vaccines, you're otherwise healthy, you really don't need a titer, you should be immune. But for healthcare workers, it's just a little different because we are going to be in the face and taking care of people with the disease, so we will check titers. And if someone needs a boost, if that titer is low, and we have a cutoff threshold, then we will give 1 vaccine to make sure we boost up titers before the person sees patients. Thank you.
Thank you so much.
Thank you. I have one more quick question. How common is SSPE? I know this is like, one of the most dreaded complications of measles. I don't think a lot of people know about it. So how common is it? And then is it like, does it affect, like, is it like boys, versus girls when, kids are affected? Is there like a sex preference, ethnicity, or what puts people at risk for SSPE? Do we know?
Great question.
That's a hard question.
No, I wish I had brushed up on SSPE, but the subsclerosing panencephalitis, so it's a neurological degenerative neurological complication of wild-type measles. It usually happens about 7 to 10 years after you acquire measles. I don't recall the predilection for males versus females, but it is, I want to say it's 1 in 1,000 or even rarer for SSPE, thankfully. It is fatal, so there is really no treatment for SSPE. And so the other issue is if you get measles in infancy, you can get SSPE even faster. Like, you don't need 7 to 10 years to develop SSPE, so you can develop SSPE earlier. So there are like real issues with SSPE, but thankfully I have not personally taken care of an SSPE, but we've had 1 diagnosis of SSPE like in like the many, many years here, so it's very rare.
Hello. My name is Guadalupe. I am a public health nurse, and I work with first-time pregnant and parenting moms. If we have babies that say they do let their pediatrician know that they'll be traveling out of the country and they'll get that dose between 6 to 11 doses, they come back and they want to be, on schedule. Is there a certain amount of time that they should wait if they got that early dose to travel internationally and then they want to come back? Is there a certain amount of time that they should wait before getting what counts as those 2 doses?
That's a great question. The shortest interval we do 1 to 2nd dose is 4 weeks. So I'd probably use the same logic there as well. So that should be fine if it is beyond 4 weeks.
Thank you. You covered a ton of material. Thank you. Thank you for a great talk, and thank you to all our speakers. Before we all leave today, I know we're hungry, everybody wants to go, but I'd like to thank again our sponsors for partnering with us and helping us to put together this conference for you guys. I would also like to thank Diego Baldonado, the theater events manager, who did an incredible job. Thank you, Diego. Also, thank you to Brian Gibson and Madeline Saylor for their top-notch IT support. I also want to thank you, AJ, Keith Darby, Gina Cromosini, and Dalia Canizales for staffing the registration table on both days for us. That was super helpful. Thank you. Thank you also to all of those who worked with me day after day for several months to make this event happen. Thank you to Angela Liang, Bonnie Holland, Brian Jimenez, and Amy Dubois. And thank you to the entire communicable disease control team for their work in preparing for the conference and their participation. There are too many of you guys to name individually, but I would like to acknowledge everybody's contribution, because without you guys, there would be no conference. Thank you also to the other San Mateo County health programs, including TB control, STI control, the Public Health Laboratory, and mosquito and vector control for staffing some of the exhibit tables. And last but not least, thank you all of you guys for attending the conference. We really enjoyed putting the program together, and I hope you enjoyed it and that you learned as much as I did. Please remember before you leave, keep this in mind, that you will need to fill out an evaluation form to receive credit for attending our program. The Stanford CME office will send you an email with a link to an online evaluation survey in 7 to 10 business days. So look out for that email. Click on the link, and then you can get your credit. Also, if you missed some lectures, if you weren't here yesterday, for instance, or you had to leave early, or if you know some people who wanted to attend the conference but could not, please remember that the conference was recorded, and so it will be available for viewing free of charge. We will let you know when the recording has been posted and where to find it, probably in a few weeks. Feel free to share the link so that others can listen to the talks and also get credit as well. Finally, we're already thinking about the next conference, and we will send you guys a save the date email as soon as we have more information. In the meantime, thank you all, and see you soon, hopefully. Thank you.